So hello everybody. So we have the pleasure to have a lecture today by Alexander SCHUSTER, who is professor at the Ophthalmic Health Research Service at the University Medical Center in Mainz, in Germany. And he was trained both as an ophthalmologist and as an epidemiologist. So he has a long experience in epidemiology, and we have met many years ago now through the European Eye Epidemiology Consortium. And I'm very happy that he accepted to do a lecture for us this morning. Alexander, the floor is yours.
Yeah. Thank you. Thank you, Cecile, for the invitation. I'm sorry my throat is a bit, so the voice is still a bit, let's call it hard, but I will give my best that you can understand the topic about in English, as my French is more understanding than actually speaking. And I have chosen the topic long-term effects of preterm birth on low birth weight on ocular health, and will explain you in the following half an hour about what we actually did about that and what this might be an impact. So just a brief summary. I'm originally coming from Swabien in the southern part of Germany, studied in Heidelberg before, medicine and medical physics, then moved to Mainz where I got a professorship, finally finished my training in epidemiology, in ophthalmology, and I'm now working in the clinics about half-time and half-time in research in epidemiology and health service research, investigating ophthalmic epidemiology and other parts of that. Based on that, we were discussing, okay, preterm birth, does this actually impact us in daily life? And when we look on WHO data, we see that about 8 to 9% of all born children are actually preterm, meaning that they're born before the gestational age of 36 weeks. And when you see the number, it's over 2 million each year born with preterm health, and thus may have an impact on ocular health and other organ development as well in the human body. If you think what are the consequences of preterm birth, you know, till the age of about 40 gestational age, babies are typically in the body itself, so they have a constant warm environment, they have a predefined nutrition by the blood and the placenta, and they have quite a constant oxygen level they get as a supply within the human body. And when they get outside of the human body, everything changes. We nowadays have incubators to somehow stabilize the environment and the temperature, but still it's not as inside the body. We try to actually have a good nutrition to somehow manage that, but still we have malnutrition and different nutrition as it would be if it's still in the body, and this has an impact on organ development. We know that organ development, like the heart, the blood vessels, and the lung itself has a large impact when they are born preterm, but we still don't know enough about the ocular health. And what we actually know up to now is that if you are born very early, you have a high risk of retinopathy of prematurity, meaning if you look on the eye like that, the vessels that are starting to grow at the central part of the optic nerve over here, they are not growing up to the front where it should be, but they stop in between. And the tissue behind that is not supplied by any oxygen, and then they start to send out some small molecules, it's called redshift, and they start to let vessels grow in different directions, finally leading to retinal detachment in this area. So this is one problem, but we still have a lot of other problems on that. Okay. More above, yeah. So when we think about the eye itself, because we're not all like ophthalmologists, we first need to know what actually the eye looks like. So you have here one sketch from the front. You see the eye itself, the pupil, that it's the aperture of like a camera of the eye. We have in the front the lens of the camera, that's meaning that it's the cornea and the lens itself. And in the back we have the retina, that is somehow the CCD detector of our camera that capture the image, and then the image itself, it's put to the brain through the optic nerve head itself, in the end somehow mimicking like a digital camera you have like maybe in your mobile phone or as a normal camera, and this is how actually we look and we are able to see. When we look in the eye, we see the retina like that with the optic disc over here and the macula in the center, And this is the point where we have the best vision. And this is quite important because it's a very small part where we can just see 100%, as we call it in Germany, or 20/20 in the UK. And if you move slightly to the right or the left, the vision goes down to about only 10%. And this is where the development of the eye has a large impact, as I show you in the following. We have nowadays imaging modalities using OCT, where you can actually have like cut through the retina without even really cutting, but just using some kind of light in corresponding to like ultrasonic devices, where you are able to visualize this somehow dipping of the retina in this area where you have the high resolution. And we have another possibility actually to measure the amount of nerve fibers that lead from the eye to the brain to the back, as showing over there, like a scan around the optic disc. And this enables us to measure how much neural tissue we have in the eye. Looking back, what we actually know about preterm children is that the retina gets thicker if you are born more premature. This is quite known for a long time in children, and you see when you get earlier in gestational age, so if you're born too early, the retina thickens, and when we think about what actually happens, we can look on how the retina and the fovea itself develops. At 25 weeks of gestational age, meaning about half of the normal developmental time, the retina has no dipping in it, as you can see in the upper part. It's still just normal layers all over the same. And while these children age normally within the human body of its mother, the dipping starts first by putting together the photoreceptors and the retinal pigment epithelium and of the outer retinal structure, and then by moving out the inner retinal structure, as you can see here. And this is important because when we have these structures still in front of the fovea, the light scattering in these regions is too high, and thus the resolution in this area might not be enough to actually see 100%, because if we think about how we actually have vision, the light comes from the roof and goes down to the bottom and has to pass through all retinal structures before it's actually captured at the wet part of the photoreceptors. And when we have more tissue in front, this is impaired and visual acuity will decrease. So keeping that in mind, we asked ourselves, okay, do we still have an impact if they are born premature but are still now adults, and what the impact might be on prematurity or in birth weight? And keeping this in mind, we started to look in the Gutenberg health study we have in Germany. If you look about here, you see Bordeaux in France, and the red dot is where about Mainz, where I come from, is. And we have something comparable to the underular study you have over here, the large population-based studies that look on prevalence and estimates in a large consortium at age 35 to 74. And within this, we had the opportunity within half an hour to do some eye examinations as part of a general examination over 6 hours using visual acuity and refraction, tonometry, so meaning measuring the intraocular pressure, measuring the size of the eye using a Lenster optical biometry. We had a small visual field examination. We had a pachymetry and keratometry, meaning a three-dimensional examination of the anterior segment. We have fundus photographs being able to analyze later on, and also using optical coherence tomography to be able to actually see whether we have this dipping and how the structures of the eye are distributed over the general population and what there might be an association with preterm birth. We also have storage of tears to maybe later on do some biobanking and analysis of that. And using this data, we looked actually how this dipping looks like. You have here again this OCT, and we just looked on the very center where the deepest position of the dipping is, and we measured how high it is, and then compared it to the birth weight that was reported by the study participants. And we see this nice association that if your birth weight is low, the thickening goes up, somehow describing that this movement of the inner structures to the side and then restructuring the retina is impaired if you have a very low birth weight. Then the question is, okay, maybe it's just a bit thicker or a bit thinner? Does it actually matter? And then we looked on distribution of eye diseases. You had yesterday this nice talk by Petra showing about age-related macular degeneration and how it looks like. And here you see a picture with drusen. That means some age-related changes in the retina, some deposits of, let's call it, structure changes over time by using the retina a lot. And you see that if you have a low birth weight, actually you have more likely having these changes due to age-related changes than if you have normal birth weight. And if you have a high birth weight, there might be a change in it as well. As we know, like for instance, for diabetes, we have things like that as well. Known that these data is adjusted for the known risk factors for AMD. So we have potentially an additional risk factor we need to keep in mind. Then the other question is it just the retina itself? Is it the photoreceptors? Or do we may have an impact on general degeneration of neural structures in the eye? And there we looked on the retinal nerve fibers, as you can see here. Same image around the optic disc as shown before. And we measure how large it is, and we can see a small, but still a small association between self-reported birth weight by the study participants showing a decrease when the birth weight is low. So the question we asked ourselves is, okay, now we know birth weight has some correlation to neural structures in the eye and to age-related changes in the eye, but actually, what is birth weight? Whom of you actually knows what birth weight is? And who knows his own birth weight? Is there anyone who knows his birth weight? So my mother told me. We had experienced the same might be true for the Gutenberg health study. So actually the study participants were asked before to look into their birth records at home and their photo albums. And in most photo albums, actually there's written somewhere the birth weight. And so about half of the study participants were able to actually report them. And we did a small subsection of them that were born in the Mainz University Hospital. And we compared the self-reported birth weight to the birth records we had there, and it was a very high correlation, about 0.95, showing that actually the self-reported data is better than we actually thought. So at least the ones that reported is quite good, but we still had only about half of it. But the question is, what is it? It's just the weight you have at birth. Nothing else, and the question is it actually more about gestational age? Meaning that the time point you are born, or whether it's actually more the size you have when you are born. So either it's large for gestational age or small for gestational age, or whether it is the size you have. And that was our hypothesis, asking, can we somehow differentiate that gestational age, hypo and hypertrophy, meaning you are large or small, in relation to when you are birth, and see whether other factors might influence ocular health as well. And now I asked you about the birth weight. Does anyone knows his gestational age? So I knew it by chance because my mother always told me I came 2 weeks later as I was supposed to come, and actually 17 days, and they started to if I wouldn't have come on this Sunday, on Monday, they would have kept me out of the body, talked me out of the body. So this was what I know, and we discussed the same in our steering committee of the Gutenberg health study, and it was like the same. We had 10 people in there, 6 knew their birth weight, and then we were discussing gestational age, and 2 knew it. So the decision was, okay, no, we won't ask our study participants because we medical doctor even do not know our own gestational age, so we can't ask them to report it, and if they would report it, it would be very unreliable. So the question was, okay, what do we do then? And we decided to build up a new cohort. It's called the Gutenberg Prematurity Eye Study. It's a retrospective cohort study we'll build up in Mainz, meaning that we went to the gynecology department and looking around and finally finding old books starting from 1969, where all births that were, or all small children that were born in Mainz are recorded. Since then, in old books. And we started to collect them, ask them if we were allowed to use them, and to identify subjects we would like to contact to know what the impact of the birth might be. Based on a selection algorithm, we decided we want to have specific premature stages, so meaning below 28 weeks of gestational age, between 29 and 32, 33 to 36, and normal birth, meaning above 37 or older. and then later, in addition, whether they are large for gestation and small, and whether they have ROP or not. And based on that, we finally decided to have 47 subjects being potentially as an invitation. And now the tricky part began. We had the names of the babies, we had the date when they were born, and we had the name of the mothers, and nothing else. And it was 69 or 75 and this age. So we started to look in our electronic medical data we had, starting in 2011, to see whether we somehow could figure out who the mothers were. We got a small proportion because movement is not so high in this area, and then we went to the registry offices and asked them again, and so we, in the end, from these 4,000 subjects, we were able to actually contact about 1,000 mothers, fathers, and finally the study participants themselves, asking whether they would be willing to come to Mainz, wherever they live in Germany, and to have an examination. And finally, 450 of these subjects came at an average age of about 30 years old, and we have a further cohort that is put underneath with full-term born large or small subjects as well. Then they got an ophthalmic examination once in the clinics, and then we moved to the Gutenberg Health Study platform as well, getting dot and eye examination because all the devices are standing around in the morning and not used, so we were able to use them in this time frame, finally leading to this distribution of our cohort, meaning that we had 140 full-term burn, moderate preterm burn is 140 about as well, and then going down. And actually, while doing the study, we finally realized how good our treatment for preterm subjects is nowadays. You may ask yourself, why are there so small numbers, like 18-1? And actually, we invited of the below weeks 28 gestation age, all subjects from starting 69. And this is because our treatment nowadays is so good that actually these people survive, but in the past one, about 90% of them died in the first years. And this changes in the 1990s, but before, very preterm subjects were not able to live anymore, and so the long-term effects of these very early subjects is quite difficult to actually capture. Then we did like normal examinations. We asked about their medical history. We did visual acuity measurements, slit lamp examination. We measured the size of the eye. We measured the macular thickness using OCT, the optic disc using OCT. We did an OCTA, meaning that we captured the very small capillaries of the retina to see whether there might be some changes in it as well, and did a three-dimensional examination of the anterior segment. And this finally led to our study cohort described over here, meaning that we have an age of about 30, and you see that in the groups 4 and 5, the very early ones, the people are younger because in the older days, the treatment of preterm birth was not as it is nowadays, and the small babies did not have a chance to survive, so they are less likely to be in our cohort that way. You see that the recruitment was going quite well. We had gestational age as it was supposed to be, and you see that all the complications like the lung being normal, the stomach and the bowel, gut being normal is less likely if you are preterm birth, and that's known complications that are treated nowadays quite well, but in the former time it was really difficult to treat them. So how is the eye affected by preterm birth? We, for instance, measured visual acuity, and this shows data about the better eye seeing, and in Germany we call it 100% or 20/20 in the UK. I think it's 10/10 over here, isn't it? You measure visual acuity, and we just looked, okay, was it able to actually see with both eyes 20/20, and you see that the more preterm birth you are, the less likely you are able to see as best corrected visual acuity, showing that about 11% of the gestational age below 28 and below, and if you have ROP, it further decreased the probability of having good vision. Looking on refractive error, meaning whether you needed glasses or not, you see it's quite stable over time, except if you have ROP or even ROP treatment, then everything changes in the eye. ROP treatment in that time, that might be different to nowadays, was that you start to destroy the retina where there are no vessels are using either cryotherapy or laser therapy, that at least the central part of the retina is restored for the rest of the life while giving up the outer part. And nowadays, treatment is slightly different by getting in medication in the eye to have the child giving a chance to further let the vessels grow in a coordinated matter to the outer part of the eye. Then we looked at the subjects, and you may have seen that in daily life, that sometimes people have some kind of a squint, meaning that not both eyes look straight ahead, but one eye might deviate to one side or the other side. It's called strabism. About 50% of subjects being born have strabismus by itself, and within the first half year of life, children learn actually to use both eyes straight ahead and being able to focus both eyes on one subject you're looking at. And when you look on premature subjects, you see that the more premature they are, the less likely they were able to actually have this neuronal development to fixate on one point, but they have a squint either to the outer part or to the inner part. And you see that with lower gestation age, you are less likely to have actually a squint in or out. And with ROP, this even further increases, especially with the squint to the inside. So keeping this in mind, you see that refractive error, strabismus, amblyopia occurring together with strabismus, and lower visual acuity even in the better eye you can see. And the question is why there might be further, even in the better eye, lower visual acuity. Thus, we looked on the OCT data. You saw this before this nice scan down here, and we measured again, and we saw that with increasing or with decreasing gestation age or with increasing prematurity, we see that the neural tissue gets smaller. Here you see also this in the graph on the left side, where you have somehow a profile over the different cohort, and you see when you do the scatter plot, it's going down with gestational age, as it somehow goes down with birth weight, because there's a high correlation between both. But with relationship to birth weight percentile, you see it's quite stable over a long time, and just in the very low one, they further go down. And keeping this in mind for later on, you see, okay, prematurity somehow has an impact on neural development that is still seen in adults and might be kept in mind when you interpret these measurements, for instance, in case of glaucoma, whether they have glaucoma or not, or whether it's just a normal eye or not. Then we looked on the optic disc itself, meaning if you look in the eye and you have this picture, you see this kind of yellow, reddish circle, and this somehow gives a view on the optic nerve head, showing that in the part where you have this reddish structure, the nerve fibers go out of the eye, and we measured how large the excavation, so the hole in the middle is in comparison to the total optic disc. And we also saw that if prematurity increases, we have a larger cupping, meaning there is less neural tissue on the optic nerve head itself. And it's slightly, as you can see, it goes up only with ROP treatment, because there everything else is different. The distribution of retinal nerve fibers is different. They have more how you call this, more structural tissue, meaning to preserve the normal nerve fibers, and that's totally different, and also the optic disc look totally different than you would have in normal optic discs. Then we moved further to the retina itself, looking on this dipping I showed you before, and there you can also see that with increasing prematurity, somehow always the same, the retinal structure goes thicker, and the question is why this might be. And there we looked on cross-sectional images. Here is a normal one by a full-tone burn subject. This looks like normal, this dipping. Then we have first stage, meaning that the dipping goes not down, but the outer structure still have the structure seen. And if you have also stage 2, no, I'm sorry, I think I put, okay, now, you see there's almost no dipping anymore. It's all images of our cohort where the fovea is somehow missing. And when you compare that about gestational age, you see that when prematurity increases, these developmental changes, that the inner structure move outside and the outer structures move inside, is somehow disturbed, leading to a lower visual acuity. I'm somehow afraid to put something. Okay. Then we had a look on the retina and do some other examinations. In this kind, an OCTA. That's, you see the image on the left upper part again, and just the blue box is now imaged. And we use repetitive OCTs, somehow ultrasound measurements, and we are able then to image the capillary network of the retina itself. And it shows in the upper part, a normal one, that in the center we don't have any vessels because they are moving out, that there's no light scattering when we actually see in the point of the sharpest vision. And when we have prematurity, this moving outwards of the retinal vessels is somehow disturbed. We have only very, very small, we call it foveal avascular zones, this yellow circle in it, and this is correlated with prematurity and also with the retinal thickness, as you can see in the lower part, that if you have a small foveal avascular zone, you have a retina itself showing that the normal retinal development is somehow disturbed by prematurity. Then another question was, and that was really changed my mind about why this study was important in the end, is if you look on the geometry of the eye. We just measure how long the eye is, as you can see from the front to the back. We measure the thickness of the cornea, the diameter of the cornea, the curvature of the cornea in front, the lens thickness, and all these different parts. And when you compare that to prematurity, you can see that the cornea gets deeper when you get more premature, as you can see in the left upper part. The diameter, meaning if you look from, in this nice picture with the pupil on it, from the left right to the right border to the cornea, this increases if you are more premature. And the axial length somehow, as in compensation for more effective power of the anterior segment, gets smaller as well, although we first expected that it might get larger, but this is just a case due to the treatment of ROP. But if you exclude ROP cases, actually the eye gets smaller as in compensation for the higher power of the anterior segment. And then we looked on what changes in the anterior segment, and we saw that the interchamber depth, meaning the space from the posterior corneal surface to the lens in front, it gets very, very thin. And we had one case that was blind on one eye, and the other eye, he had a high pressure because he actually had, when he came to our examination, an acute ankle closure situation. And if he would not be treated within the next few days, he would have lost vision on his only eye. And then we finally realized, okay, prematurity has actually an impact on our daily treating of cases, and especially of those that had an ROP treatment in the past. And within the next few years, although not recognizing this before, we had about 10 to 15 cases that actually came with an acute ankle closure and having had ROP treatment in the past. Just no one had recognized before that actually this was the reason, because the morphology of the eye in these cases is different, and thus they need like a lifelong regular checkup to rule out acute ankle closure in these subjects. And that's because after ROP treatment, the lens gets thicker. Why? We actually don't know. We just know that it gets thicker. It might be due to different metabolism, due to the laser treatment destroying the retina itself, and that might change the lens structure as well, and this leading to a shallow anterior chamber. So I somehow explained to you birth weight and its high correlation to gestational age. It's still somehow missing small and large for gestational age, meaning whether this hypertrophy might have an impact as well. And that was the reason why we added some additional groups for subjects born at term, but being very small at term or very large at term. Very large might be because the mothers have diabetes, that's quite a known risk factor, and being small might be that the placenta is not working as it should be, or there might be other reasons behind why they are very small. So we looked on somehow the same as before. You see here again the retinal nerve fiber layer thickness. It gets thinner if you have a very low birth weight percentile born at term, and it's still about the lower 20%. It's the same as in the preterm birth, but also in the full-term birth. And we still see in the very low ones that we have a larger cupping in the optic disc. When we look on the retina itself, we don't find any association, meaning that this is really a prematurity reason, or prematurity really leads to the distribution of the retinal nerve structures in the fovea itself, and it's not hypertrophy. And when we look on the dimensions of the eye itself, we see that somehow it's similar to what we see in prematurity, that we actually have a steepening of the anterior segment, while the size itself, it's quite not impacted by itself. So the posterior part, it's less likely to be impacted by hypertrophy, while the anterior segment it is. To sum all this up, we know that prematurity has an impact on foveal development, as shown, and also on visual acuity that is still present in adulthood, and might have an impact on the development of age-related diseases like age-related macular degeneration. We have some hints being based on the Gutenberg Health Study, but still our participants are too young to actually be able to take any clue out of this. We know that RNFL thickness is thinner, and this may show a reduced reserve capacity for neurodegeneration diseases. Actually, they don't had many glaucoma cases. We had like 2 glaucoma cases, and one I already told you about this ankle closure case. So yet the patients are too young for glaucoma, and yet we don't know whether this might have an impact over time. We did some additional analysis showing whether we have some effect modification by age, and up to now we couldn't find it. So it's still the possibility that they are born with less neural tissue, they have less reserve capacity, and therefore they might be less susceptible to changes due to glaucoma, leading to then a worse outcome in the end. We know that visual acuity is lower in subjects, especially in those with ROP, and that the ocular morphology is altered by prematurity, especially in those with ROP and ROP treatment in the end, and might result in ankle closure cases, and they actually need regular checkups, the very preterm born subjects. What we will do the next few years, we now apply for funding for follow-up examination of these old people, hopefully also in 10 or 20 years, because actually then they are old enough to get the eye diseases we were actually focusing on. It's still too young with 30. You should be about 15 average to be able to detect age-related eye diseases. We are looking whether we have this neurodegeneration, whether it's just being less built up during your developmental phase as a very small child or neonatal, or whether we have it over time. We will see that, and retinal degeneration over time as well. And we started to build up a new cohort of children starting from age 4 to 17, but actually the 4-year-old ones are very tough to examine, so it started really at 6. We skipped it later on to slightly older ones, because we had a lot of change in prematurity treatment in the last 20 years. And it's not as in the 60s or 70s, where the baby that just came out of her body, if it was premature, it was taken from the mother, put in an incubator, and the parents were allowed to get it back after 4 to 8 weeks, when it was thought that now it's old enough to get into society. And nowadays, if you are born premature, the mothers are there all the time. They get skin contact each day. They are able to breastfeed them very early to have a nice connection. And this changed a lot of the treatment of prematurity and might have an impact on ocular health and other health issues as well, especially psychosocial health that is really impaired in these subjects if they are born very early. This is the aim for the next few years. We will see how it will work on and what we are able to show you like in 5 to 10 years on that. It's not only that it's my work, but it's a lot of people standing behind that from different departments and also from different specialties in the eye clinics itself. With that, I want to thank you, and who might watch this talk on the YouTube channel, you can write me an email if you have any answers or any questions on that. You see my email over here, and I'm happy to answer any questions you have.